Welcome, everybody. I'd like to call the meeting to order. It is 5 p.m. First up, like last month, I'm going to just say a couple things about our community partners, and actually one of them is with Windsor Regional Hospital. It's Hats On for Healthcare. The 12th annual Hats On for Healthcare launched yesterday. What is traditionally a one-day in-person event will be a month-long online campaign this year. So be sure to find a hat and make a donation to support Windsor Regional Hospital Foundation's COVID-19 Assistance Fund. And then for more information, you can register for the event. Go right to the WRH website or www.hatsonforhealthcare.ca. And then the second thing we have is Dr. Disc is selling t-shirts featuring their original nurse design for $20 at their store. Proceeds from the t-shirt sales will be supporting the Windsor Regional Hospital Foundation's COVID-19 Assistance Fund as well. So head downtown and be sure to grab a shirt to support a great cause. So hold on, we'll show you what the shirt looks like. All right, so, sorry, I don't know how to do the, so anyways, those are my two things for this month. So remember, hat, and go down to Dr. Disc and support one of your local businesses. So yes, take that guy off. Whew. All right, first up today, we have a presentation from Evolve, who is, their presentation's going to explain it. Don't want to steal their thunder. So
I think it's the same day hip and knee presentation that's going first.
Oh, I apologize. I went backwards. So the presentation on same day hips and knees will go first and then Evolve.
Yes, thank you.
Sorry.
So also in attendance is I have Dr. Mike McCaffrey, who's the subsection chief for orthopedics, and Jen Trukulak. She's the director of perioperative. The hospitals in Ontario Health West had an opportunity to develop plans to decrease the surgical backlog with financial support from the Ministry of Health. Instead of each hospital submitting their plans, a working team was organized and we developed a regional approach within a regional plan was submitted and approved. This plan is a pilot project called Same Day Home Joints. It's 17 pilot sites. What this means for Windsor Regional is to increase our volume of our same day total and reverse shoulders, but to also implement a plan for total hip and knee replacements that go home the same day. We received $150,000 from Ontario Health West to purchase equipment to support these orthopedic cases. Next slide. So as a region and individual hospitals, we developed inclusion and exclusion criteria for the patients. The patient is scheduled the first case of the day. We standardized pre-op and post-op medications with order sets, standardized anesthesia, and also discharge criteria. We have a dedicated location with a dedicated team. The patient is followed up with a phone call and a survey and outpatient physiotherapy. This just gives us a quick overview of some of the standard documents we have and how we have a SEMI on each site that's named Same Day Home Joint Area. That's where the patients go. It's on the same floor that physio's on, so it's good access for physio. They have paper brochures for their care and a booklet on their hip replacement and what's expected. We are developing an app for their My Care journey. Next. So some of the benefits, as I've already listed, it's a regional approach, it's evidence-based standard of care, it's best practice. It also increases access to care for same-day patients and patients needing a bed. So currently, our last year in the OR, orthopedic surgeons have a full day of operating, but they've only been given one bed. So that one bed was taken by a patient that needed a joint replacement. But now that first case of the day, that patient gets to go home and the second patient gets a bed. So really, we're doing 2 surgeries for the price of 1 bed. The cases are completed closer to home. The patient gets to recover in their own home. And it's conservative bed days is 2 to 3 days, depending on if you're a hip or knee. So it does reduce hospital costs for that patient, but then those costs are invested in the next patient. So when we looked at our data, the next slide, we talked about patient volumes. You have on the left-hand side the surgical procedure. The funded cases is what the ministry target, and it's supported with a financial QBP dollars for every year. What we're looking at is 40% of those patients will have in the queue could fit the criteria for hip and knee, same day joint replacement, and 80% of our shoulders. The last column gives you an idea of the patients this would affect. So just under 600 patients in the patient population we have could benefit from the same day home joint program. When we look at our successes on the next slide, we implemented the hip and knee same day on March the 15th. And as of yesterday, we completed 6 hips and 10 knees. We had an 83% success rate with the hips. That's 5 out of 6 patients, and 9 out of 10, 90% success rate with knees. And when we review every patient, and when we looked at why these 2 weren't successful, it was not because of the surgery, it was related to another underlying condition. And for shoulders, we call it scaled because we were doing some same day home shoulders in the past, but now we're really doing a focused approach. We've done 37 shoulders with 100% success rate. So what our next steps are is really regionalizing and standardizing our order sets, patient education, developing a dashboard, and looking at our documentation. So Dr. McCaffrey?
Hello.
Please see me.
Yeah, well, thank you very much, Rosemary. So we've been working hard on this project, and basically what it's come down to is access of care. So the novel coronavirus has really made us look at novel ways of providing treatment to patients. And the number of patients needing joint replacements is not decreasing, it's increasing. But unfortunately, our access to beds has been decreasing. So we looked at ways that we could increase access for our patients because we know they're suffering at home with their joint pain. So we looked around and we know that actually the same day joint replacement surgeries, it's not a new model. It's been used in the United States for several years now with their outpatient surgical centers. It's been used in London and Hamilton and Toronto. And really this, the need has really prompted us to develop this program here in our LHIN. As Rosemary said, we've had great success so far. We've had excellent feedback from our patients. Patients are actually coming into the office now asking if they can go home the same day. So I think so far it's been a great success. It's not only a success for the hospital and the healthcare system, but also for the patients. And I'm hoping this is something that we can expand into the future.
So does anybody have any questions?
You beat me to it.
Sorry.
Sorry, I'm just scrolling through everybody, so bear with me. Cynthia.
Just wondering, it sounds great, especially if you're the patient waiting at home for your joint replacement. In the discharge planning, do you have home care going to that patient's home, like an arrangement for that discharge planning? Or is that necessary?
So I'll answer that. It's Jenny. So in regards to the discharge planning, so we do follow-up calls the next day with the patient. So I myself actually call the patients and follow up with the surgeon that did the surgery. Their plan of care is already set out for when they go home. So we haven't had the need for, if they do need the LIN to go in to do any treatment, right now, we haven't had any patients that actually require that. They are seeing the patients go and see the surgeons within a week and a half to 2 weeks in the clinics. And they're also going to physio if they're a knee getting done. They're going to physio within a few days. So we haven't really had to have anything in-house as of yet. And the patients have had their own care partners at home helping them. So they've actually succeeded so far.
Follow up with.
So again, with the inclusion criteria, the patients have to fit this certain category so they will be successful. So we learn from other hospitals what worked for them and what didn't work for the patients. So you take that criteria and hand pick the patients, and you have to be very careful of the patients you pick. Make sure that they have family support at home and that they're going to be successful.
Yeah, and it's important to note too that during the evaluation process pre-op, there's several chances for the patient to be taken out of the pathway when they're seen by the anesthesiologist, for instance. If they feel the patient's not appropriate, the anesthesiologist can make a recommendation that the patient is admitted. When they're seen by the physiotherapist for their pre-op evaluation, if the physiotherapist thinks that they won't be a good candidate, they can be taken out of the pathway as well. So they're evaluated by multiple health professionals, and there has to be a consensus with everyone that they're a good candidate.
No, thank you. Follow up for Cynthia.
Yes, so that's really good because things could change even along the way. In the pre-op teaching, does that involve their caregiver or someone like, say, for anticoagulant therapy or anything?
It does. We have, we bring their caregiver in with them when they come into pre-assessment. So they are met with the anesthesia, the physio at that time. Not anticoagulant though. Right?
They're seen by an internal medicine physician.
Yeah, so yeah, that's true. So they're seen by internal medicines that would cover some of that anticoagulant, but we do bring their care partners. When following up with the other hospitals, that was one of the things that they found successful, is that you have to have your care partner in there for the pre-op.
One of the exclusion criteria is that if a patient is on a blood thinner and it's not well controlled, that would be one of the exclusion criteria for the patient.
Thank you.
Lori. Once again, I will unmute you. You're all set.
Hi. Thank you. Are they going home with any type of block for pain control? Like, do they go with an external block in place for pain control, or are you just giving regular medication for pain control?
So pain control is a major aspect of this program. They're given a multimodal cocktail pre-op, and they're given multimodal painkillers intraoperatively. Preoperatively, they're given a block, but there's no pain pump that they go home with. And then postoperatively, they're also given several analgesics to go home with.
Yeah, because that's what I would have considered probably your bigger problem is pain control for these people once they've left the hospital. Because and what happens if they get into like a pain crisis? Is there somebody they can reach out to?
Hasn't been an issue
so
far in any of the patients we've had. I mean, that would be something we can address if it becomes a problem. That hasn't been a problem thus far.
Great, thank you.
When patients are discharged, they do have a contact phone number in case they do get into crisis or if they have any questions. When reviewing other hospitals, patients that weren't successful, two issues were frequent. One is pain management. The other issue was their inability to void post-op. So we've looked at that with anesthesia and made sure that the cocktail, like Dr. McCaffrey talked about, is something that's appropriate and has been covering their pain so far.
Any other questions? I think David had his hand up.
Yes, thank you. So an ongoing question that continues to get raised is the issue of the number of surgeries, not only locally, but provincially, that have been delayed as a result of COVID and as a result of restrictions and COVID patients and census in the hospital, et cetera. So just because for everyone to appreciate is from a planning point of view, by being able to do a good proportion of the patients using the same day joint, Rosemary, Jen, Dr. McCaffrey, could you explain the impact that has on access to services, beds, and the like?
So I can start. So we can, between 40 and 50%, we're behind in the volume of joints we need to catch up on. When I looked in our scheduling system just yesterday, we're about just under 400 joints are scheduled. So if you can do two joints in a day over 5 days, if they have the OR time for them, that will catch up in double the time, because one patient, first patient of the day, gets to go home and that bed goes to the second patient. So we almost get like 2 for 1, do 2 surgeries, 1 bed. When I spoke to several of the orthopedic surgeons, and they're saying they have, a list of 6 months is, and they have wait times. If you want to address wait times that you're seeing in your office for patients needing surgery, Dr. McCaffrey?
Well, our wait lists have increased. Certainly some surgeons with an arthroplasty heavy practice recently have had their lists grow considerably because of our inability to get patients into the system. Like, for instance, Dr. JC and Dr. Bisland, who have a very heavy hip and knee replacement surgery practice, have seen over the last 6 months their wait lists grow incredibly long. So I think having the opportunity to get some of these patients off the wait list and into the hospital with outpatient surgery is going to be a huge benefit.
Oh, great. Any other questions or comments? No, thank you, Dr. McCaffrey. Appreciate that. And Rosemary, appreciate it. Pretty incredible stuff that we're doing. All of these things that we're talking about today will lead into that stage 2 planning. And I don't want to steal David's thunder, but these types of procedures really do change the way healthcare is provided within the region and really does speed things up. So great job to everybody on this initiative. Appreciate it.
Thank you. Thanks, Jen.
Thanks, Jen. Sorry, I apologize. Next up, we have the Evolve has a presentation.
So let's talk about Evolve. Evolve was a program established a couple years ago to implement a hospital information system across the region. What does that look like? What does that feel like? It is essentially taking our current paper records and make it into an electronic patient record.
So what we're doing now is standardizing at both campuses with the same hospital information system, if not actually upgrading it to even a better system that we had. So we are replacing 2 outdated systems that were end of support, one at each campus.
It is all aimed to improve patient care. There are various aspects of improvement in patient care. One of these aspects is a regionalization of the hospital chart. The hospital chart will be available for all physicians to see, whether a patient is at Windsor Regional Hospital, Erie Shores, Chatham-Kent, Hotel du Grace.
So what does it mean to have a connected electronic patient record for our patients across the system?
Improved patient care, improved patient safety, improved outcome. Overall, I would say the experience is going to be enhanced because of this system upgrade. so our patients can interact with our providers more effectively. We'll have access to more integrated tools to provide more efficient, seamless care across the continuum, across our program, across all acute care hospitals.
So our current system is, paper charting, very slow. Only one person can be in the chart at a time, and it requires manual handover of information between providers. With the new system, we'll have digital information which is immediately transferred onto the system and available to everybody providing care simultaneously.
As well, we have standardized order sets that are best practice order sets that will regionalize best practice across our region.
From a healthcare provider perspective, really having quick access to up-to-date patient records ensures that we improve patient outcomes and improve the timeliness of access to care for our community.
This will alleviate a lot of those problems and enhance patient safety measures and communication with the entire interprofessional team.
I think that what we'll see is we're saving a lot of time. We're able to provide care, access the records right at point of care, provide the care directly to the patient in a more timely manner, and it will actually be more efficient for our staff.
We tried to make the patient experience the same for our patients, and now we're doing the same for our staff.
A quality-focused healthcare is really predicated on learning, designing, and implementing system changes that are necessary to respond to a dynamic healthcare environment. And that's what we're in. We're in a very dynamic healthcare system, and we need the infrastructure that lets us respond to that.
In this incredible year where we've faced so much uncertainty as a result of the pandemic, having a connected patient record across the region just becomes that much more important. And the fact that all of these hospitals across the region, all of the staff, as well as Transform, have worked hard to deliver that and are doing it in the midst of a global pandemic is pretty remarkable. And I thank each and every one of them for all of their efforts in getting this very important project done for our patients and our community.
First, thanks everybody. That's a great video, good synopsis of what's to come. Did anybody want to speak to the Evolve and the new system? Questions or comments with regards to the video? I think it's T minus, oh, sorry, Penny, go ahead. Hold on, Penny, you're just muted.
The doctors who have their own offices and their patients are there, but they also do have privileges in the hospital, in some cases to, take care of the patients that go to the hospital. Are they going to get Evolve on their computers in their offices? Or are they going to have to do that? Or get the patient records,
That's a good question, Penny, if you want me to answer it, Anthony.
Yes, please, Dr. Sun.
Yeah, unfortunately, it doesn't, they're not the same system. So every physician in the community has their own EMR. Even those EMRs are not talking to each other or connected to each other. But the one advantage is that all the hospitals, whether it's acute care or non-acute, are going to be connected, and the information that does come from a hospital visit is able to be transferred and sent to a private EMR. So that communication goes back and forth, but there is no other link or connection, and nobody else has this hospital, has this EMR in their private office.
Okay, well, that's good to know. Thank you.
So just want to say, I think it's T minus 9 days now. Correct me if I'm wrong. 9 days, 10 days, 10 days. So still a lot of work to be done. The amount of work associated with upgrading a health information system is monumental. This is wholesale changes throughout the hospital. This is extra hours put in by everybody at the hospital. It is truly a feat to get this done and done during a pandemic. Congratulations to everybody. I'm knocking on wood right now that it goes as smoothly as all of us are hoping, and we are prepared for both the best and the worst case scenarios. So I think that's David's old favorite comment. Prepare for the worst, hope for the best, and you're ready for everything in between. I can't remember the exact comment, but I think it's close. Any other questions or comments with regards to that? None? Perfect. All right, can I get declarations of conflict of interest? Seeing none, wonderful, thank you. Can I get a motion to approve the previous minutes? So I have Michael, seconded by Paul Lachance. Questions or comments with regards to those minutes? Seeing none, all in favor? Perfect, thank you so much. First, now on to normal business. We have the report of the president and CEO.
Thank you, Mr. Chair. Yeah, just following up with respect to Evolve. Any implementation of electronic health record, especially as you outlined to this scale, let alone during a pandemic, is difficult. I guarantee, kind of like the location of the hospital, we're not going to make everybody happy. The implementation of the EMR, it's not going to go smooth. It's going to go as smooth as we can get it, but there will be bumps. There will be hurdles. There will be weeks, if not months, following its implementation, working out all of the various issues. What we tried to do as a region is for Windsor Regional to go last, recognizing it would be the most complex and we could learn from the others. So that's what we've done. What we didn't count on was the pandemic. And as a result, that threw us another curveball. So everyone has done an amazing job to get to this point. And like you said, we're T-minus 10 days and counting. And we will get through it. But it will be very difficult and very complicated. And as long as we recognize that as a team, that it is not going to be anywhere near perfect, and it's going to take months. You talk to any other hospital anywhere in the world that has implemented a system like this at this scale, as Rosemary's praying, it is met with difficulties, and it is not easy. But the team's committed, and we're ready. If there's one thing that we've recognized going back to the days of realignment, is how to get through issues as a team and how to work through issues. We've been tested with floods, with old infrastructure, et cetera, et cetera, et cetera. I can list them off, and everyone pulling together to make it happen. So I'm confident, beyond confident, that's going to happen, and we will move through this, but it won't be easy. But it will work. Second issue talk about is what Mr. Chair identified is the announcement with respect to moving to stage 2, and not only the announcement in the budget, but also having $9.8 million set aside for the necessary planning to make that a reality. I can indicate we've already had very productive discussions with the capital group at the Ministry of Health, and we are actively proceeding with getting it all lined up and getting in a position to start the stage 2 planning. As indicated, that's what's called functional programming, and that's where you put into words how a hospital is going to be operated, how it's going to function, what it's going to look like, visual in words. And then we pick those words up, hand them to an architect, and the architect then designs the hospital around those words rather than the other way around. So it's function leads design, not design leads function, meaning you can design the most beautiful hospital in the world, but if it's not functional, then it's not operational and not worth that much. So the goal is to make sure the clinical teams are actively engaged with respect to the functional program, and that's a lot of fun to be a part of, as the clinical and non-clinical teams is it's something different in the sense of you can work at a hospital for your whole life and not have an opportunity to be part of something like this. So it's pretty exciting with respect to existing staff. And I can tell you any staff we've recruited to the hospital always talks about it with respect to being involved in that and wanting to be involved in it. In any interview I've been in with professional staff, every single one of them mentions it, that they look forward to being part of it. And so it's going to be pretty exciting moving forward. Then in addition, making sure we, as we always have, engage the community. Anyone who wants to be involved in this is going to have an opportunity to be involved. We posted on our internet site actually back in December regarding how that will happen, how that will unfold, where individuals from the community say they're interested in cancer. We'll have an opportunity to be a part of that planning and that discussion regarding what the cancer program is going to look like moving forward. What we've always said with respect to quote services is, under promise, over deliver. Look forward to some very productive discussions with the ministry with respect to not only our current but future delivery of services for our region. And the one thing we've learned from COVID, and I'm going to get into that next, it wouldn't be a meeting in the last year without talking about COVID, is how you have to look at the province as a province. Is one thing COVID has really solidified is we are a provincial healthcare system. Technically, we're not even a regional healthcare system, meaning we're all there for each other across the whole province. And I'll get into that as we move forward and with respect to the announcement today from Premier Ford. So that's the third thing, and I have a PowerPoint slide to go through. But just to give you some context, as we heard today, the whole province, effective 12:01 a.m. Saturday morning, is going to move to a provincial lockdown. And I talked about it even this morning, when we started hearing about it, and we didn't have any inside information with respect to it more than what the public had at that time. But I know that's very frustrating for residents of Windsor-Essex, because if we look at our COVID numbers locally, generally we have low positive cases on a daily basis, a lot lower than when we were at 300-400 a day. In the hospital, at least at Windsor Regional, we have 8 current active COVID positive patients, 2 in the ICU. They range in age from 50 to 90. So they're in the traditional wild virus demographics. Nothing unique about that. We're not seeing, quote, the younger population that other ICUs and hospitals are seeing across the province. And it's frustrating that back in August, when Windsor-Essex was in rough shape and the province announced opening up parts of the province, Windsor-Essex was, quote, left behind. And the rest of the province opened up and Windsor-Essex had to stay behind. So I would imagine now, I know, is people in the community are saying, well, hang on here. We're like doing fine. We're doing great as a community adhering to public health measures. Why are we being lumped in with the rest of the province when the rest of the province goes into lockdown or gray? Why don't we get the benefit of what we've been doing, stay in where we're at, if not go better, and continue to open? The difference between August and now is this concept of variants, how easily they're spread, the impact of them, and how quickly they're spread. And you cannot isolate one part of our province and say, okay, you're immune to these changes and the rest are implemented, because human nature is human nature. Unless you put up a border, people are going to come to your community from outside and bring that, quote, variant in rather quickly, and they don't have to travel far to do that. So I totally understand the frustration. I get it. I'm frustrated. And it's a difficult time, but that's kind of the context. And I'll try to go through with my slides what we're looking at. You can see that? Beautiful. Okay. So we look back. So that's what I just talked about, is looking back at wave 2. What happened during wave 2 that we can learn from, you know, what took place and how we were doing. So you can see from this green line, what we're talking about here is how the overall inpatient lines continued to increase, and the ICU continued to increase with a peak ICU census of 421 effective January 15th. And that was the highest amount of patients in the ICU being COVID positive across the province. And then if you look up where January 12th, that was when the stay-at-home order was put into place. And you can see pretty much from the moment it was put into place, the numbers started dropping rapidly with respect to COVID, both as inpatients and COVID both in the ICU, and the impact that that stay in order had on both hospitalizations and ICU patients. So where we're at with respect to looking forward in wave 3, this is what the province was looking at. And if you see this 409 numbers, the number of patients in the ICU as of March 28th, it's now April 1st. That number today was reported at 430 COVID positive patients in ICU. And if you recall the previous slide, the highest amount we got in wave 2 was 421. So technically we're in wave 3. Where we're at in wave 3 is probably more towards the earlier part of wave 3 than the later part, but we already have 430 patients in the ICU across the province, in the ICUs. This 1090 number, I think, is somewhere closing in on 1,200. And if you look projected by April 4th, the projected number is 477 and 1324. And if we did nothing already by April 18th, we would have almost double the amount of inpatients in the hospital and close to 700 patients in the ICUs COVID positive if we did nothing. So clearly we had to do something. Premier Ford's decision, I was asked about it. He was in a no-win situation, meaning if he doesn't announce anything, he's going to be criticized for not announcing anything, because people like myself would be popping up this chart and showing this is where we're going to be by April 4th and April 18th by doing nothing. By doing something, he then, of course, goes back. And as I stated, the frustration is evident, and especially from, say, jurisdictions like Windsor, Essex, that feel that everything's fine. Why are we having to go through this? We don't need to go through this. So that's kind of where we're at. And where we get to the provincial system from is we are in active discussions, as I think I stated at the last board meeting or board meeting before, and it's been stated publicly, is we are in regular discussions with respect to our role provincially to help across the province. So what is happening now on a daily basis is patients are moved either in critical care and or general medicine from those hospitals that are struggling to meet the demands, and patients are being moved to those hospitals that can help. We're part of those hospitals that, of course, can help. And our team is ready, able, and willing to help. The province, we have regular discussions multiple times a day on being able to help. And there's what's called an IMS structure for our West region that involves ourselves as Windsor Regional, London CEO, St. Mary's, and Hamilton. And we talk as a group with respect to being ready on our operational tables to accept patients from outside of our region, from those quote hotspots in the region, which is primarily in the GTA area right now. So there is, I hope it doesn't happen, but we're ready again if we need to help to take patients from outside of our region into our facilities, be it ourselves, Chatham, Blue Water, Erie Shores, and then Hotel Dieu helping from a subacute point of view as well, and being able to help deal with this wave 3 and the impact it has on the ICUs and inpatients in any fashion. So just looking forward with respect to wave 3, I've talked about this before as well, as how kind of we're in this artificial bubble in Windsor, Essex right now. Again, the reverse of what was going on in August is they test now all of the positive results for COVID to determine if they're a variant of concern. As of a week ago, our numbers were only 8.7% of our COVID positive cases were classified as a variant of concern. And as of this morning, we only had 6 variants of concern confirmed as UK variant in Windsor, Essex. So it takes some time to, number one, be identified as a variant of concern, and then to determine exactly which variant of concern it is, be it UK, Brazilian, South African, etc. Now compare that to the province. The province is, and this number is old even, the province, is north of 60% of its COVID cases are variants of concern. And if you recall back a month ago, that was the projection, is that we'd be at 30-40% by the middle of March. And sure enough, we are, and we're north of that now. So when it comes to our experience, the variants of concern are, we haven't felt it yet. And I hope we never feel it. And I hope because of the lockdown, we don't feel it in Windsor, Essex. That would be great. Because if we can help the rest of the province move through this quicker, then that allows Windsor, Essex to move through this quicker as well, in the sense of a region, and to be able to get back to where we need to get back to in 4 weeks' time. So where it says key findings, today the science table released a report, and this is taken directly from the report. These are their words, where it says the third wave is here and is being driven by variants of concern. Outside of Windsor, Essex, younger Ontarians are ending up at the hospital, and they've determined that the risk of an ICU admission is 2 times higher, and the risk of death is 1.5 times higher for the B117 variant, which is the UK variant. And as stated, COVID threatens healthcare system ability to deal with regular ICU admissions and the ability to care for patients. 2 quotes is scientific quotes from the scientists involved at the science table back a week ago indicated the variant's new data shows the pandemic's out of control. And then the CDC, the director of CDC, with respect to what's going on in the United States, she said, she has a feeling of impending doom. And for that to come from a director of the CDC, that needs to be taken seriously. If she's concerned about that, and again, you don't have to look far. I don't know what Michigan's numbers were today, but yesterday there were over 6,000 positives. I mean, I know when they were running, 4 was a big number before. And I think they were just declared by the CDC as the state with the highest positivity rate in all of the United States. So this slide is from the science table slides. It shows patients in inpatient beds with COVID-19 pretty much up to April 1st, and then patients in the ICU. You can see the red line is the ICU. And just over the last 2 weeks, there's been a 41.7% increase in hospitalizations alone. And that's a trend line that's got to stop, because we can't go back to what we were facing in January, where you see that so high. Now, this is another slide, and this is telling because it shows what the age percentage of weekly COVID-19 admissions by age. And it identifies the difference we were facing in December to what we're facing now, where between just March 15th and the 21st, look at the number of people that were admitted to ICUs across the province between the ages of 0 and 60 is 73, as compared to back in December for a similar time period, it was only 45. So it does show that their point is that there is a younger age group demographic being impacted by the variant more severely across the province, and it's not what we're seeing locally yet. And I hope we never see it. We don't want to see this. It's bad enough what we've been through in December. We don't want this to start impacting our younger age group in Windsor, Essex, like it is the rest of the province. And I'm hopeful that because of the 28-day lockdown, emergency break, whatever you want to call it, that will hopefully help us not get to this point. And the fact that it's being applied across the whole province consistently, again, will avoid arguably someone coming into our region thinking the restaurants are open, whatever's available, and then as a result spreading this. And I talked to the CEOs in the region that have the variants, and it's not good. It is putting major stress on their system. And then couple it, I'll talk about it in a bit, is this issue is dealing with the surgical backlog. What we're able to take advantage of right now is the fact that we don't have these cases and we can do these surgeries and trying to get through this quote backlog and do things like Dr. McCaffrey, Rosemary, and Jen talked about, is the same day joints and procedures like that to try to maximize as many quote joints as we can do in a given day to deal with the backlog. And that's what we've been able to accomplish because of what Windsor Essex has done as residents in adhering to public health measures and keeping COVID positive cases low. And as a result, when you keep them low, you don't have hospitalizations, you don't have critical care admissions. We can try to do more and more cases as we can, the best we can. By having this 4-week lockdown, again, that helps us do this, and also hopefully will have the same impact that the previous lockdown had, as I indicated in the first slide. As it drops dramatically, the rest of the province can hopefully reduce the pressure on them, not have to send patients to Windsor, Essex, even though, again, we're up for that. And in 4 weeks, we'll be in a much better position as a province and as a region. In the meantime, we can continue to do our surgical cases. So one of the questions we were asked in the public is, because of the lockdown, is that going to affect surgeries? No, we're going to keep doing it. What will affect surgeries, though, is if we have to start taking patients from outside of the region, then we'll have to examine that, the impact that has. Again, hopefully that doesn't have to happen, but again, we have to act as a province with respect to healthcare, and we'll have to deal with that if that comes up. But again, hopefully by going through this parking break or emergency break lockdown, we can continue to do surgeries. The province can get the line going down, and we can do exactly what they said at the science table advisory, which is these orders will control the surge, protect access to care, and increase the chance of the summer Ontarians want, that all of us want. So that is why they had to do what they had to do. That is why Premier Ford had to announce what he announced. And I don't know about you, but I look at him and he's got stress all over his face. This has eaten him alive to do this. You know, we know the stress we're under and his stress has to be 200 times more than ours, if not more. And like I stated, he was in a no-win. He can't win with this decision. He's going to upset a whole bunch of people, no matter which way it cuts. But this line here from the science table is exactly it. Is if we don't do this now for the whole province, then we're going to have a lot of problems, and we won't. If you want to get the summer and enjoy your summer and try to have more freedoms and more, quote, back to normal, we're not going to get there. So that's my presentation, Mr. Chair.
Thank you, David.
Take any questions.
Yeah, I assume there will be a couple questions. Everybody's in awe. So David, just to clarify, 6,000 in Michigan today, 6,000 plus again today, and they had their first Brazilian variant pop up. So things do not look rosy on the other side of the border currently. Lori?
Just a quick question. I know you didn't talk about the vaccines, but a lot of this is predicated on our slow rollout of the vaccines across the province. Any news about picking that up and moving that along? I keep reading in the news that, you know, we have this group in the 70s who are being a little resistant to getting the vaccine. And do you know if there are any plans to like maybe let the 60-year-olds come and get the vaccine if the 70s aren't going to take it, or are we going to do some health education?
We're doing all of it, all the above. So we're continuing to try to promote the 70 plus gaining access to the vaccine, meaning wanting to go get the vaccine. There's a bunch of factors that it'd be great if 100% got that. That's not going to happen. I think some of the factors preventing individuals from now totally embracing the vaccine is, number one, the news stories with respect to AstraZeneca, which depending on the day, that flips from left to right to center. That then, even though it's AstraZeneca, starts impacting the opinion of some of the other vaccines for some of the population. Then on top of it, you have the issue of the quote delay of the second dose to 4 months. Some people are saying, I'll wait, you know, if once they're able to give the 2 doses together, I'll get them both together, you know, either 21 or 28 days. So you got that. Third thing is our numbers are low, and Windsor, Essex. So some people are like, oh, you know, everything's good. We're fine. So I'm not wishing for numbers to go up to change that attitude. But I think when you couple all 3 of those things together, plus there's going to be a certain portion of your population. We saw some statistics today that it's about 20% to 25% of the 70 plus will not, they have vaccine hesitancy. That doesn't even take into account all the factors I just outlined. That's kind of like the raw number, just vaccine hesitancy, period, no matter what the vaccine is. So yes, so we're actively promoting vaccines, trying to reduce the stigma and all the myths that are out there that all the Facebook medical degrees have earned. All the people on Facebook who earned their medical degree from the University of Facebook are out there spewing. And so we're trying to get over that. But at the same time, yes, there's active discussions regarding, quote, dropping the age group. And there's more to come with respect to that, hopefully very shortly. And that'll be directed through WeChew, the health unit. Dr. Ahmed will be directing that. And again, we're working very closely on the vaccine front with WeChew, City of Windsor, County of Essex, Erie Shores. Everybody has got their fingers involved in the vaccine in the sense of, and we're all working very closely and collaboratively. I wish we had tens of thousands of vaccines but I'll give you an example. When we get to the start of business on Monday, Easter Monday, we'll have less than 1,000 vaccines in the freezer, meaning we won't have enough vaccines if we don't get the shipment Monday to finish Monday's schedule. So we are using up every single vaccine we have in our freezers. Dr. Ahmed has said this publicly. When you compare us provincially, even though we wish we were better, our percentage of vaccine, quote, reach they use is very high as compared to the rest of the province, meaning we have put a lot of vaccines in a lot of arms as compared to the rest of the province, even though we want to be much better, not only locally, but provincially. So everyone's trying to do their best. You know, again, just another note for the public. If you hear there's a drop or something like that, we are open online to go online, go to the WeChoose site. If you go to our site, you'll be directed to the WeChoose site. You can book online. It's very easy to book online. If you don't have access to a computer, our staff, along with the Windsor staff, are all working together as City of Windsor. And we have tomorrow we'll have upwards of 12 to 15 people working all Easter weekend, no time off, like they stop at 8 o'clock at night tomorrow night, but answering the phones. So those who don't have access to a computer can call in and book an appointment over the phone.
David, would they do this through 311?
No. There's a number to call. Do not call 311. Do not call 211. There's a number at the WeChoose site. It starts with 22 something. So it's just go to the WeChoose site, wechu.org. Right on the front, it says book, and it has the number. It's 226 something.
226-773-2200.
Thank you. So remember that. So call that number. You can book. If you're 70 plus and you don't have the vaccine yet, call tonight, 6 o'clock. They're there till 8. Call. You'll get in. You'll get booked. You'll get the vaccine. All the sites are really smooth, really good. I mean, St. Clair does the most. If you want to look at numbers, in a given day, St. Clair's pumping out 850, north of 850. We've pumped as much as 1,000 on a given day. There, we could do more if we had more vaccines. WFCU does about, I think, 560 a day. Downtown does 350 a day. And Amherstburg and Leamington, depending on which site, does about 150 a day. Downtown, you literally, if you get dropped off, you fall out of your car, you're inside the building. It's the sidewalk you got to cross. There's people there to help you out of your car. There's free parking on the street. There's a surface lot right across the street. So if you're dropped off, the person who dropped you off can come in with you, stay with you. You go through the front door, get your mask, get your shield, go get vaccinated. You're out of there within half an hour. And you get a little chocolate bar on your way out. That's a big hit, chocolate bars on the way out. And if you don't get a chocolate bar, St. Clair asks for it. So, because they do have tons of chocolate bars to hand out. You get a chocolate bar on your way out and everything's smooth. So, and you know, your loved one can drive around. There's a pickup center at downtown, same at St. Clair, same at WFCU, same at Libro, same at Leamington. It is very smooth. Last thing on that point, I know that's a long-winded answer to your vaccine question, is don't show up early. You know, like my mom's 82, and if she's not there 2 hours before an appointment, she's late. So just literally, you're booked. We book them for a certain time. Show up 15 minutes before. I've told people on the phones, even show up a little bit late, it's fine. We'll take care of you. Show up 15 minutes before, you'll get in and get out. What happened early on is, and we knew this, but we tried to publicize it, is people were showing up 2 hours early. Like the doors open at 8 and there are people there at like 6:30 in the morning, you know, banging on the glass. So it's just show up 15 minutes before, you're good to go, get you in and out, nice and safe. What happens if at St. Clair, if we're doing, 120 people an hour, if those 120 show up with their loved ones, that's 240. If you get another 240 showing up, and people love lines, meaning once they see a line, they go in it. That's the other thing too, is no matter, so if you go to St. Clair now, there's these big signs we put up, electronic signs. There's 3 of them that say, stay in your car until 15 minutes before your appointment. And when you drive up, there's a security guard that says to you, are you here for your first dose? Stay in your car. You're a little early. Stay in your car 15 minutes and then come on in. And it's only first dose. We'll get the second doses. It's right now the word is 4 months. It could be less, but for now it's 4 months to the second dose. So sorry, Lori, that's a long-winded answer to vaccines. You ask me about vaccines, you're going to get a long-winded answer.
Pam? Oh, you're on mute, Pam. You're all
okay. I just wanted to attest that everything David said is true. I was at St. Clair College earlier this week getting my vaccine, and it was so easy, so thorough, so professional. It was a painless, literally a painless experience. So kudos to everybody who set that up. It's as smooth as silk.
Did you get a chocolate bar?
I did, which my grandson ate, sadly, but yes. I wanted to go back and get 2.
You can have 2. Don't worry about it. Actually, the chocolate bar is kind of a funny story, because when UHN started it, we're on like the first call with UHN because they went first. And they said, tip to everybody, get chocolate bars. Mm-hmm. We're like, really? And they said, people want chocolate bars for whatever reason. And just, so we got them at St. Clair, Windsor, Windsor Essex Family Services provided us, they donated like 2,000 chocolate bars in addition. So that was great. And we handled these chocolate bars. St. Clair, big bins of them. We sometimes forget, and people are like, where's the chocolate bar? So we're working on the chocolate bar. So I'm glad, Pam, you got the chocolate bar. So yeah. Well done, Karen. Karen wiped her brow because she was like, whew.
So I'm just going to reiterate what David said about, I think Dr. Saad said it best on AM 800, and I've used this with both my parents, is it's not an international flight, people. You don't have to get there 2 hours beforehand. So please pretend it's Windsor Airport. 5 minutes before your flight, you just walk up and you're there. So just stay calm. Everybody will get through the line. There is no line.
Yeah.
Pam.
And a final comment, from everything I've seen, certainly around where I live, the pharmacies for AstraZeneca were overwhelmed with people. The girl told me at St. Clair College, they're trying to do 1,000 a day. It was packed with people who were eager to get their jab. So I'm not sure if Windsor is one of the groups of places that's showing vaccine resistance, because everything I've seen, people can't wait to get it.
Yeah, it's just again, going back to Lori's point, we would love to have 80-90% of the particular age group want the vaccine and get it. We're not there. So will we get there? Possibly, but so it's work in progress, and it's not only locally, it's provincially, it's nationally. You look at what's happening in the United States, they're already into 16 and above getting vaccinated. But if you look at their national numbers, I haven't looked at them lately, but I don't know if they're north of 50% yet with first dose. So will they top out at 60? Probably. Good chance. Mm-hmm. That's where they're going to cap out at. So and that's we look at our flu vaccinations, et cetera. The good thing about it is our staff, very positive rates so far with our staff. You've seen the emails on that, so that's good. So very positive.
90% and above, David, for our staff.
About 85, 80,
85.
85, so it's good. Yeah.
Perfect, thank you. All right, if no more questions, we will move on to Dr. Jacobs. I think the shadows. Dr. Jacobs.
Hi there, thank you very much. Getting the sun right behind me, I apologize. Brief report today. One would be with respect to our fourth year students. So they are all on target to graduate on time. They're doing the last set of rotations now. They have 3 more sets of 2 weeks blocks, but they're, touch wood, they've achieved all of the expected competencies to graduate as expected. So despite all the stress we've had getting them through this, I'm glad to say that they're all on schedule for that. They will have match day on April the 20th. That'll be where they find it will. They'll be doing the residencies. Obviously, that's a high stress situation for them, but typically the Windsor class has done very well with respect to their match, and so we hope this year will be no different. With respect to the new stage 2 of the hospital moving forward, the school is very excited to explore, what types of things that we can suggest to capitalize on your good fortune, if you will. I mean, I'll speak from the Shula cap for a second, but I do think it's exciting to really think about how the academic side really does integrate well into the new design, and so we're very excited about that. So from our side, that's an exciting opportunity. And then the last thing I wanted to bring up is, despite the news of the day, we are still hopeful that eventually we'll be able to move forward with internationalizing our campus. That is still on the docket and what we're planning towards. And so our hope actually will be that in a couple of years, we might talk about having some American students join us here at the Windsor campus. The work on that is going forward. Takes a while to get that going, but that's what we're working towards going forward. That's all I have, boss. Thanks.
Wow, exciting stuff. Any questions for Dr. Jacobs? No. Well, we're glad you're here and glad we're going to be looking forward to some valuable insight from Shulik as we move through stage 2. So thank you. Next up, we have the financial presentation and treasurer's report. Penny Allen.
Yep. We got slides. That's good. Yes, this was as of February 28th, which is the 11th month. So yes, the year-to-date deficit for the hospital operations is $14,986,000. Revenue is $16.6 million favorable to date. Total expenses are $31.5 million unfavorable, but that's largest variance in salaries and wages, and with the slides coming up, a lot of it is COVID. So COVID-19 unfunded expenses date in the amount of $14.4 million. The deficit after the net building amortization is $17,325,000, sorry about that. And it should be noted that if the unfunded COVID-19 expenses had been funded as incurred, the year-to-date deficit would have been $2.9 million and a positive hospital margin of $1,349,000. And when it says when it's incurred, I think I've mentioned this before, the expenses, the hospital has to send in information to the Ministry of Health to get the funding back. And so if it's the expenses is in January, you're not going to get it in January. You're going to get it 2 to 3 months later. So that's why there's a gap. So that's okay. And then this one is this is the impact year to date of the financial results, which for unfunded and what is not unfunded by the ministry. So you can see funded has been well for operating 27 million, but they're still unfunded at 14 million. So again, that's waiting around, generally speaking, for them to pay. Yeah. Okay, and year-to-date revenue, I'll just sort of highlight a little bit of it. The 27 million COVID reimbursements to date for April to November operating expenses included a one-time funding. And anyways, you can read the rest, and it says there's year-to-date unearned revenues for urgent and emergent quality-based procedure is 13.9 million to date. And 820,000 revenue shortfall in complex malignant hematology due to volume decreases. And that's, I would expect, because COVID is sort of bumping elective issues too. So, okay. Next is the patient services is 834,000 year to date, and it's trending favorably in the last 6 months, which is good. And ministry drug reimbursements is also favorable, 3.7, and other recoveries, 304,000 favorable, with the retail pharmacies, 3.2 million favorable, but losses in the parking and retail food operations are 2.9 million unfavorable to date. And it's a question whether we're going to get some of that reimbursement from the ministry. It's not like completely dead, where it could be some good news. So overall revenue favorable. And then the salaries and wages, 13.5 million unfavorable. Generally speaking, it all has to do, the 1.4 million unfavorable in the month of February, with COVID's extra screening staff and vaccine staff, and sick and isolation pay for staff members. And then the inpatient medicine and critical care surge staffing at 475,000. The medical staff remuneration is 2.9 million unfavorable in the month, again, due to 12.5 million in COVID-related payments. And then the medical surgical supplies, again, there's a lot to do with COVID, 2.3 million unfavorable. And then mainly more PPE and general supplies, mask gowns, and additional 4.1 million for N95 masks. So a lot of that it comes from the COVID issue again. And then year-to-date expenses, drugs are 6 million unfavorable. Chemo and renal drug expenses and recoveries are balanced. But retail pharmacy net drug expense to revenue is 255,000 favorable. The other supplies and expenses are unfavorable, and you can see there's in the month 627,000 favorable in the month for cataract cases, building service equipment, higher laundry costs, and yes, and lab supplies. So yes, the patient accent. Here, I just want to check something. Both MET and OLET acute care are over the expected length of stay, while the psychiatry programs are under the expected average length of stay. And then the patient volumes, well, you can see again all along the volumes are down from February 2020 because basically of COVID and people not wanting to go to the hospital, I believe. So that's the patient volumes. And then we have the sick time and overtime. Sick time and overtime are worse than the target at both MET and OLET. 9% of total paid sick hours to date are due to COVID-19, and the benchmarks would be the 5.5% at MET and 5.6% at OLET if these costs were not incurred. So a lot of this is really impacted by COVID-19 costs. So then, just a second here. Yes. Oh, yeah. Okay, so now I will move that the financial report with the February 28, 2021 results presented at the April 1st, 2021 meeting to be accepted.
Perfect. Thank you. Seconded by Lori. Thank you, Lori. Does anybody have any questions or comments with regards to this? Seeing none, I've got to say, Penny, that's a great report. I mean, the amount of work that Mark and his team put together.
It's Mark and his team, yes.
It's exceptional. So
Yes.
Overall, very good numbers in a very, very trying year. So keep up the good work, Mark and team.
Yes.
Thank you, Penny.
Yeah.
All in favor? Wonderful. Thank you so much. That has been accepted. And then I think we have the consent agenda.
Yes, I have that motion again, that the report from the March 22nd, 2021 Financial Audit and Resources Committee meeting be accepted. That's basically the minutes. Yeah.
Perfect. Thank you. Seconded by Pam Skillings. Thank you, Pam. Questions or comments? Seeing none, all in favor? Wonderful. Thank you so much. In the printed materials, we have the corresponding media report. That's an FYI. Do we have any other questions or comments currently? Seeing none. Wonderful. Thank you. So the date of our next meeting is Thursday, May the 6th. And that is good. So can I get a motion to adjourn? Genevieve, thank you. Seconded by Dan Wilson. Appreciate that. I don't think anybody's going to oppose that, but all in favor? Perfect. Thank you. So for the members, please log back in at about 6:25 so we can be prompt.
Yes.
Again, and thank you again to everybody. Windsor, please stay safe. Get vaccinated, and if you have elderly parents, please help them. If you have an elderly neighbor or even just a regular neighbor that isn't tech savvy, please help them get signed up for their vaccinations. This is probably off camera now, so I'm just blathering to the people that know to go get vaccinated. But again, have a good weekend, everybody, and thanks.